on quality improvement, and even think about subspecialization to create more in-country expertise. And one of those areas of subspecialization is pediatric emergency medicine. And that is near and dear to my heart because it is what I do. And what I do with that expertise at home and in other settings is I teach a lot of general practitioners and emergency medicine physicians about how best to care for children. And that's really important because worldwide, it is not generally people like me, pediatric emergency medicine physicians, taking care of kids when they are ill or injured. It is generally going to be those general practitioners. So it's important that everyone has some pediatric knowledge and that every emergency department is ready to take care of children. So I'm going to be speaking about that today, pediatric readiness. We'll talk about what that means. We'll go over the importance and patient impact of readiness. We'll review some aspects of a framework of readiness, and we'll discuss how you might begin to implement this in your own practice settings. So this is the definition. Pediatric readiness is a hospital's ability to provide care for children who are injured or ill. It includes having the right staff, the right equipment, and the right processes to treat children. So what is the impact of this? Well, in the United States, they've done a lot of looking at pediatric readiness of general emergency departments. So emergency departments that take care of all ages. And they created a scale. They marked down staff, equipment, processes, and they gave each of these emergency departments a score from 0 to 100. And then they looked to see if the scores were related to outcomes. And this is what they found. They looked at 20,483 critically ill children, so very ill children, at 426 hospitals. And they found that those with the highest preparedness, the highest readiness, had only a 3.4% mortality rate. The fourth quartile, the lowest readiness, had an 11.1% mortality, so more than 3 times different. So from that setting, they began to really think that it was important to have this readiness, that critically ill children presenting to hospitals with pediatric readiness scores that are high have decreased in-hospital mortality. And that really makes sense because it means that they are ready to take care of these children, right? But they've done a lot more research to begin to try and solidify this into evidence and encourage more hospitals to have high pediatric readiness. So these are a few of the studies that they've done in the US. They've looked at more than 800 emergency departments that have trauma centers, so take care of trauma patients. And they saw that if a patient was first seen at a trauma center that had the highest preparedness, they had half the risk of death. They looked at almost 800,000 children in almost 1,000 EDs, and they saw that if children presented with either medical illness or trauma, they had significantly lower chances of death, 60% and 76% respectively, if they were at those highest readiness facilities. And they estimate that if all emergency departments in the United States were brought up to the average, not even 100%, but an average readiness score, which is in the 70s, they would save thousands of lives every year. So in the US, this resulted in a national effort to improve pediatric readiness, which is called the National PRP, or Pediatric Readiness Project. So as I was going through this and thinking about giving this talk here, I was wondering to myself, could increased readiness improve the care for pediatric patients here in Tanzania? So I began to think about the aspects that made readiness important. Well, first, readiness is talking about the ability to take care of children. And Tanzania has a very young population. So Dr. Said was talking to us yesterday about the makeup of the Tanzanian population, and he told us that 42.8% of the population are 0 to 14 years. In the US, 0 to 14 years is only 17% of our population. So you have a much larger pediatric population that could be impacted by pediatric readiness. Pediatric patients, when they present to EMDs here, are often very sick. They're critically ill with high acuity. We have data from several places across the country that shows this, from Mwanza, Mbeya, KCMC, Muhimbili. We know that kids present very sick, and they are the children that are most important to be ready for. In low and middle income countries worldwide, including this one, emergency departments rarely serve only pediatric patients. They generally serve everyone who comes in of all ages. And those are the exact type of emergency departments that need to have specific readiness for children to make sure that they can cover patients of all ages. And pediatric patients here make up a larger portion of the EMD patients compared to the US or the UK. There's simply a higher percentage of children being seen. So with all of that, all of the areas, the reasons why we have readiness for pediatrics and find it so important are higher here in Tanzania than in the US or the UK. And so my hypothesis is really that improving pediatric readiness will improve outcomes for children in Tanzania, and it might even have a higher impact than it would in settings like mine. So with that hypothesis, I wanted to introduce to you some models and standards for pediatric care. There are a number of organizations that have provided models and standards for care. They include IFEM, AFEM, the WHO, UK, and American organizations, and there are many more. But if you look at the standards that they set out, how do you begin to translate that into what you need to have in your emergency department? A recent article that was published last month with authors from the US, Nigeria, Kenya, and South Africa created a novel tool to assess pediatric readiness, and it's an excellent tool. It's also based on the same framework that I'm going to speak to you about today. And that framework is from the National PRP, and it includes these elements of looking at pediatric preparedness. Looks at administration and coordination, care teams, quality, procedures, policies, support services, being safe for patients, and then equipment, supplies, and medication. And we're going to touch on each of these areas just to talk a little bit about how we might focus on them to be ready for pediatric patients. If you go to the National PRP website, you can see their list. And I made a little video to show you. It's multiple pages, and it has checkbox items that really go through a lot of the things that this organization thought were key to taking care of pediatric patients. But it's a long list. But if you're interested in that level of detail, you can certainly go and find it online. So the areas it goes through are administration and coordination. And one of the aspects that they believe is very important is to have somebody that is really interested, invested, and responsible for making sure that your department is ready for children. They suggest having a physician coordinator for pediatric care and a nursing coordinator for pediatric care that sort of lead your department in this area. When your team is having training, they want to make sure that you have pediatric-specific training that you incorporate, and that your CPD also includes children, because they're an important part of your EMD population. Whenever you have a quality or process improvement initiative, caring for children is part of what you do, and so those QI plans should include specific pediatric indicators. And when you look at the care of pediatric patients, system changes can be made based on the performance in caring for children. It's essential that all department-wide initiatives in departments that care for children include children when they are being planned. Policies, procedures, and protocols, that's a giant category. But again, it is the idea that when you are setting a policy, a procedure, or a protocol for your department, you want to make sure that pediatrics are included, or make a separate policy if it doesn't translate to the pediatric population. There are also some policies that are suggested to have for pediatric patients that are unique to pediatric patients. So some of those are listed here, and you're not meant to be able to see all of them, but they are several. So what to do in cases where you're concerned there's child abuse? What do you do if there is no guardian with the patient that you are taking care of? Do you have specific procedures and policies for sedation, analgesia, in pediatric patients? So as you go through and make SOPs for your department, if you can include children in the department SOPs, that's an excellent thing to do, but for some things, you'll need to create separate pediatric ones. Looking at your support services. So all of the departments that help you take care of patients, and making sure that they have appropriate policies and procedures for kids. One example is radiology. So if you are going to send a pediatric patient to radiology, you want to make sure that they have appropriate protocols to decrease radiation for children, to get good images on children. Another could be the lab. If you are taking blood from a very tiny baby, you do not want to have to fill up a giant tube of blood. You want pediatric size equipment for that. So working with the other departments in the hospital to try to make sure that you have those aspects for pediatric care. Pediatric patient and medication safety. So we have to consider some special aspects of taking care of children that put them at possible risk or harm when they are in the emergency department. One of these examples is falls. So babies that are crawling, if you put them on a general stretcher that doesn't have anything from stopping them from falling off, they can definitely have a serious fall. So we want to make sure that that kind of thing does not happen. And then one of the most common errors in pediatric medicine overall, including pediatric medicine in the emergency department, is medication errors, because it's weight-based medications. And doing calculations make people prone to error. So especially on high-risk medicines, where an error would potentially cause harm to the patient, you want very specific protocols that make sure that you're getting the right dose based on weight to the patient. Equipment, supplies, and medicines. So it's important to make sure that your department has equipment for all sizes of children, because there is nothing worse than having a child come in that is not breathing, where you know exactly what to do, but you just don't have the right size bag valve mask. So trying to make sure that your department is set with equipment for all sizes of patients, along with sort of one-time use equipment, looking at the equipment that you use over and over, things like monitors, defibrillator pads, all of those should have pediatric options available to you as well. And then ensuring that you have essential pediatric medications to take care of children in emergencies. So the WHO has a list of essential pediatric medications. The AFEM textbook has a list of essential pediatric medications. The American Academy of Pediatrics does too. There's several options and they overlap quite a bit. But making sure that you have the medicines available in your department that you could give to children in cases of emergency. So that was just touching on the surface of each of those categories. But I wanted to give you an overall idea of some of the aspects of pediatric readiness that you could consider for your emergency departments. And as I begin to end my talk, I urge you to really think about how you could do it in your department. But don't get overwhelmed, because not all of these things have to happen at once. As we saw, improved readiness improves mortality rates. So if you can slowly, step by step, address some of these things, with each improvement, you are likely to begin to improve care and improve mortality. It's small steps, but it will go a long way. So I wanted to provide you with some pediatric readiness resources. The checklist that I showed in the beginning is the first one. The WHO Essential Medications for Children is excellent. IFEM has standards of care for children, and there's also UK standards of care that are very good for almost any environment. And EMAT has a pediatric emergency care book. They had it at the table yesterday that gives some specific pediatric care recommendations for Tanzania. And if you're interested in pediatric emergency medicine, I also invite you to join our lecture series. So my university, Emory and MUHAS, have begun to put on a pediatric EM lecture series. And if you'd like more information about that, you can follow EM MUHAS on Instagram or Twitter. Thank you so much.
Thank you very much, Professor Brittany. Yeah. Readiness should be exercised everywhere when you're in acute care settings. And I have to tell you that I brought my fellow doctors and nurses from my department so that they can learn out of this, whether in pediatrics, whether in adult medicine, ACU, emergency, you should be ready. They say if you fail to prepare, prepare to fail. Thank you very much. Our next speaker is Dr. Joseph Boni. Dr. Joseph Boni is an emergency physician from Accra, Ghana. He's an emergency medicine specialist at Komfo Anokye Teaching Hospital and research fellow with the Global Health and Infectious Diseases Research Group at the Kumasi Collaborative Center for Research in Tropical Medicine. Dr. Joseph Boni is an emergency medicine specialist from Ghana. He holds a master's in public health. He specialized in health service planning and management from the Kwame Nkrumah University of Science and Technology, and master's in disaster medicine, MSc-DM, from the Cremedin Center for Research and Training in Disaster Medicine, Humanitarian Aid and Global Health, University of Eastern Piedmont. Currently, he works as an emergency medicine specialist and attending physician at the Komfo Anokye Teaching Hospital. Emergency medicine is a directorate and is part of the directorate and heads of research and innovation office in the same directorate. Dr. Boni is a research fellow with the Global Health and Infectious Disease Group at the Kumasi. and he is the current president of African Federation of Emergency Medicine. Today morning, Dr. Joseph Boni is going to talk about the emergency medicine in Africa, low identity, international impact. Welcome, Doctor.
Hi, good morning, everyone. Okay. Excellent, thank you. It's a really great pleasure to be here to speak to you this morning, last day of a brilliant conference. So this morning we're speaking about emergency medicine, the local identity and international impact. There's just going to be a little twist on this presentation, where I'm going to show some examples of such great local impacts that we're wondering why these have not been internationalized yet. So I'm already been introduced and there's no conflict of interest. So just so we are aware, emergency medicine is a specialty that concerns ourselves with illness and injuries requiring immediate attention. We all know this, but also what we know is that we serve as an entry point. So the minute you have things that generate from emergency medicine, it can quickly cascade into other areas within the hospital. Some years ago, the thought about emergency medicine in Africa was an abstract idea, one training in some tiny place and nothing else happening. But now it's not like that anymore. It's living, breathing, and growing quite rapidly across the entire continent. So what is emergency medicine and what does it mean to you? In lots of places around the world, and I really like this world map because it's almost proportionally correct to show how big Africa is. We have a big landmass and a big area and a huge population who are all developing through emergency care to develop systems that will work for them. So the definition of emergency medicine is very different in various parts of the world. For somebody, this is their definition of emergency care. This is what they see, and at this point, this is what triggers them to think, we should start a program. We should have some services that can take care of people when they're in this need. In other areas, this is emergency care. And this is a picture of an emergency physician in Ethiopia who decided to take it on and renovate her emergency department. So the definition of emergency care continues to evolve. A local identity and defining African emergency medicine, the unique challenges that has led to innovative solutions. And I'll speak about a few of them. How many of us have an ambulance service that we can rely on and say, when I call them, within 5 to 10 minutes, we'll be at my residence in an African country? Nobody? One person. Where is this? United States. Okay. So, but how many of us have a taxi service that is less than 5 minutes from your house drive? Is it just me? Okay. So at some point, we decided to ask these taxi drivers because, one, we noticed that they were so close to everybody's house, and taxi services that I'm speaking about is not black or yellow cabs. I'm speaking about the regular taxi services that will commute people from one place to the other. And we asked them, what usually happens when there's an incident at the roadside? And because, one, they have a transport system and they're readily available, they ended up becoming the first point of call. And even in the communities, pregnant women will identify a taxi driver who lives close to them and say that if I did go into labor, I will call this person to take me to the hospital. So we asked them whether they had responded to a mass casualty event before. And to our surprise, almost 40% of them had responded before, and a lot of them had responded more than once. And at the scene, almost all of them transported a patient. Interestingly, they all still believe that having an ambulance is still the most effective way. Over 70% of them thought so. But since it was not available, they were happy and willing to learn and pick up skills and be able to support an ambulance service if necessary. Such an innovation is what can be propagated. Teach the people who are there and available to be able to provide the care and not invest in huge resources in ambulance services when the country cannot afford it at that point in time. Another example is work that was done looking at motorcycles being your first responder to a site. So instead of a $100,000 ambulance, we're sending a $1,500 motorcycle to the site. And we ran this as a normal test trial. They set up from the same place, they had one location, and they were both supposed to get there. And in a time trial setting, they got there 5 minutes, 6 seconds before the van did. And this is the van with all its sirens and everything and driving through traffic. This just means that whoever was injured or has an effect at the site had 5 minutes more time to get some medical direction. They didn't need to transport the patient. They could give medical direction whilst waiting for a van to get there. These are innovations that have been seen and needs to be propagated. In other places in the world, when you say you are not well, you will have a system that will tell you there are no beds in this institution, you can be transferred to this one. We're diverting all the patients to this place. We're moving all pediatric patients here. Burns patients have a burns center, etc. In a lot of our emergency departments, you are the first and last stop. If they can't come to you, they can't go anywhere else. Because all that skill is now concentrated in that one teaching hospital, and if you can't take care of them, your next referral site is very, very far away. This leads to events of overcrowding. This is the entrance of my emergency department, and this is almost always the case. 2 ambulances parked in front. And we took this picture strategically because there are like 6 ambulances hiding right in the corner, and they're all waiting for a bed to offload a patient. So one, the few ambulances that you have are already caught in this mess, and they're bringing you all the patients with no chance of diverting a patient. So looking at this, a tiny device, a mobile phone, not a smartphone, just a mobile phone that can do text messaging, could allow clinicians from various places to send a text and say, I have space in my hospital. Can you send me a patient instead of sending them to this place? These have evolved into WhatsApp groups among pediatricians, among neonatologists, among emergency physicians. And this has clearly reduced the burden of neonatal emergencies in our region. Hasn't really done much for the adult emergencies, but I'm sure it's getting there. Another example of local effects that have sprung on to international recognition is this. This is something that we should recognize. How many of us know this and use this on a daily basis? Okay, so the South African Triage Score. This was developed in South Africa, but quickly has been spread across a lot of African countries. And in comparison with other triage skills, it provides you more of a foolproof measure for catching the cases that might not be as clear-cut using the discriminator list. This has made it very possible for us to look at what condition would you present with, irrespective of your vital signs, and use that to be able to categorize you per a situation. This also took in mind what resources might be available or not be available, and will encourage you to say you would need this as a basic minimum in your emergency department. Part of this has led to the development of what an emergency resuscitation looks like at the WHO level. But not only have we looked at such innovations that really should be internationalized, but we've also looked at defining who the workforce should be. A complete African emergency physician. What really do we need from this person? So educational-wise, we have residency programs, and we're very happy to see how these continue to grow. Certificate courses and fellowships and training courses. There's still a lot of work that needs to be done in this space, but there are international certificate courses that are now available for people to take here. And without a doubt, there is no difference between running these courses in Africa, the knowledge level, the skill level, and how it is run anywhere across the world, showing that we really didn't need local adaptation. We already had the international knowledge and skill. Also, basic emergency care course, and for those of us that don't know the true history, was developed in Africa, and now it's been sprung across the world. And I can see Petra nodding because some of those scripts that were written by her and other people, and has grown to be a WHO product that is being spread across the world. We have manuals that have been developed through African contest, and yesterday I was very proud to see the mechanical ventilation beyond basics, and then also all the huge manuals that have been developed by EMAT that are available just outside the room. These books are of international standards, and I can bet you are some of the best books that you might have seen across the continent. The fellowship programs give us a really long list, and I was very happy to hear about pediatric emergency medicine. But are we developing this well enough? I think these are areas where if we need to have that level of international appeal, we should be able to develop our fellowship programs to a point where they work. Leave the silos and decide to collaborate. If you have pediatricians and emergency medicine in one hospital, you can definitely develop a pediatric emergency medicine program. If you have radiology and emergency medicine in one hospital, there's no reason why you cannot develop an ultrasound fellowship program. This is what is expected of an African emergency leader. Right out of school, you're expected to be an advocate, an educator, a clinician, a researcher, and a leader. And it becomes very hard because you have to take up all these roles in one. And sometimes, some of the roles that you take up, you find out after a couple of years that it was actually somebody's full-time job. A lot of us have been tweaking our ventilators here and there, but that is a respiratory therapist's job. And whenever you have people visiting our ED in various parts of Kumasi and Accra, they're surprised how we troubleshoot our ventilators and get them from saying not working to has passed the test and a patient can be on this ventilator. But usually this ends up making us very tired. And this is where we need to build a skill and have people that can support us. Research focused on African and African disease burden is what will change the scope. A lot of the work that we do cannot be seen externally. But when you put out a good research paper, a good publication, it resonates. People are able to see this, people are able to know the work that is happening, and people would know how to collaborate with you. But Africa is the worst research site. Everybody wants to keep their data in their hospital, write about that tiny small paper, be the first author, and not share. Even worse, you have to put everybody in your department on that paper, whether they know about it or not know about it, because then you're not going to get promoted. But Africa can also be the best research site. Let's link up the departments. Let's know what is happening in Uganda, South Africa, Egypt, and Tanzania. Let's have a common data set so that we can compare results, build a big data set, and then this will definitely increase the impact. Because the next pandemic is coming, and it's coming really fast. And we all know that at some point, we have seen examples of when we as emergency physicians put in the effort and stopped it in its tracks, or we let it go and it spread out. Ebola in West Africa, late clinician identification. By the time there was identification, it had spread to so many people, and it was just rampaging throughout Sierra Leone, Liberia, and a lot of West African countries. But we had a case of Marburg in Ghana. The clinician thought about it, tested the first patient, contact traced, and we stopped it at 6 patients. But these are examples of when clinicians decide that we're putting research in the center. And this is a unique opportunity for us in Africa in our emergency departments. We see so many more patients than our colleagues in any other part of the world. We see such diverse patients. And if we're able to include our research in the emergency departments, we create this golden space where we're able to capture what happens in our emergency departments in research outputs and research outlines. Because more impact is created here. The research that we do will improve the healthcare, will improve global healthcare, and feed back into health policies that can help change policies not just in Africa, but globally. An example is putting in a research office in your emergency department, where researchers can have a place to sit and work. And this has shown tremendous improvements in areas where they have this, with large number of publications from their departments, and also the development of registries, which can capture large amounts of data, allowing you to be able to compare. So from all of this, we've noticed one thing: we do not copy and paste. Far from it. We have been innovating and doing this so well, but we have not been telling the story that well. So we are resourceful, we're adaptive, and we're community-driven. And the examples that we have shown here have shown beyond doubt that really, is it local trying to be international, or it probably should be the other way around. So our impact, training models that have been adapted internationally, research informing outbreaks and responses, and disaster and emergency preparedness strategies that have grown to be global. And we look at COVID-19, Mpox, Ebola, and Marburg, and all of this research leading global work. A lot of it can happen and should be happening in Africa, where the burden is. I already talked about BEC, grown from Africa, spread across the world, and then community-driven solutions for disaster and emergency preparedness, which have grown from the Ubuntu idea of Africa. This is a call to action. We need to shape our own narrative. The African emergency should be central for global health discussion. You might be invited to a meeting because you are the only African who has to be there, but do not take that as a negative effect. When you're in that meeting, channel the energy to let people know you should be there, and it's not just because of your identity. Strengthen the partnerships that we have, and we saw great partnership with governments, academia, and global international institutes. Sustain and grow an African emergency medicine leadership, because if people stay and work and grow the discipline, that is when we can see our international effects. So, international thinking for a local problem, not the other way around. Not a local thinking for an international problem, but think internationally. The solution I am putting in here, can we use that same solution in the UK, in US, in India? It has to be standard. Clear up the problem and don't just clean it up. And this is some of the biggest problems. How many of us have emergency departments that will suddenly become spanky looking, well organized when the Minister of Health says he's visiting? Overnight, everything seems to be fixed, everything seems to be perfect, and we paint the wrong picture to the people that can fix the problem. So if there is a problem, let's all come together to clear it up and not just clean it up and make it shiny looking. Always think standards. If I can do it here, I should be able to do it in Cape Town, I should be able to do it in New York, I should be able to do it in New Delhi. If I cannot do it around the world, and this is not standard, you should not be doing it in your hospital. Along with quality assurance. So we work around the world, but we mostly work in Africa. And we need to tell the story, because Africa truly is leading. This image, I am sure, is recognized by everybody in the room, and we're going to put a test. Who knows what this image is? If I can see your hands up, please. Oh, hands, not fingers. Come on, we know what this is. Everybody. I need your hands up so that I can put it to a test to the next one. Hands, hands, not fingers. Are people in this room telling me they have no idea what this is? Okay, good. How many of us know what this is? you would realize something. Nobody needed to tell us about this because this story has been told over and over and over again. There has been a plan to tell the story about what this image is and what it represents. But apparently, there are people that live in Arusha that do not know that this is supposed to be the center of Africa, which is between Cape Town and Cairo. And I learned that this morning. So we need to tell our own story. In conclusion, Africa is leading. Let us build an emergency system that reflects who we are, strengthen our continent, and influence the world. At this point, this was my topic, local identity, international impact. But I think this is what it should be, international identity with a local impact. Thank you very much.
Thank you very much, Dr. Boni. Dr. Boni has been stressing on the collaboration in Africa, innovation to have a global impact. The next speaker in this morning is Professor Jeremiah Seni. Professor Jeremiah Seni is an associate professor of microbiology and infectious diseases at the Catholic University of Health and Allied Sciences, KUHAS, that is at Bugando Medical Center in Mwanza, Tanzania. I work with him. He is currently serving as the Director of Postgraduate Studies at KUHAS and Antimicrobial Resistance AMR Surveillance, lead and co-lead in the Emergency Preparedness and Response at Bugando Medical Center. His 15 years of clinical and research experience has been on delineation of transmission dynamics and impact assessment of multi-drug resistant pathogens of public health importance, setting up hospital-based AMR surveillance and antimicrobial stewardship systems, evaluating cost-effective diagnostics, developing evidence-based guidelines on infectious disease treatment, prevention and control use of One Health approach. He has provided technical expertise to various institutions in the country, regionally and globally, with recent one on the WHO Global AMR Research Agenda in the human health sector in June 2023. He is currently working on the incremental predictive potentials for various inflammatory markers of sepsis among critically ill patients at the emergency and intensive care units. Professor Seni is a member of Global Alliance for Infections in Surgery, a member of Tanzanian Multisectorial Coordinating Committee on AMR. He is the member of the National Biosafety and Biosecurity Technical Working Group, TWG, and the National Chairperson of the AMS TWG. He published over 100 technical reports and peer-reviewed research articles. Professor Seni, welcome. And today morning, he's going to talk about the inflammatory markers for sepsis, the outcome predictions in the ER and the ICU settings.
Good morning, everyone. I'm really grateful to the organizing committee to welcome me to give a talk in this important conference. Thank you very much. So I'm really grateful to the organizing committee to welcome me to be one of the keynote speakers in this important conference We understand that emergency medicine and critical care services are rapidly evolving, and especially in Africa, Tanzania in particular, and bringing the multidisciplinary, multi-sectoral collaboration in this venture is very, very critical. So when I was approached by colleagues, I was really grateful that we bring in the infectious disease expertise as well in this emergency medicine arena. So I think I don't want to introduce myself. Dr. Ali has done a great job. So this is the research team and collaborators that have been working together, and I don't have any conflict of interest to declare from what I'm going to present here. So this is the outline. So I'll give you the overview on what is our university and our tertiary hospital, Bugando Medical Center, and then the burden of COVID, because that's where my talk will be. And then I'll highlight on the principle underpinning these inflammatory markers, and then I'll then delineate on how we can use them in prediction of outcomes of patients who are admitted, either who are in the emergency medicine department or those who are admitted in a critical care unit in our settings. And then I'll also finish by highlighting the clinical and public health implications on this. So this is Africa in the small, that's a map, and this is where Tanzania is. And what you see here, that's the catchment population for our hospital. So our hospital is serving a catchment population of approximately 20 million people in the northwestern part of Tanzania. And this is like catering for 8 administrative regions in that area. And our hospital has over 1,000 beds, and we have like approximately 115 admissions every day. And if you put this together, we have a total of like close to 200,000 annual patient days. And in 2021, we actually commemorated the 50th anniversary for the hospital, and 2 years ago, we also commemorated the 20th anniversary for our university. So these are 2 institutions which are 2 in 1, same premises, same workforce, and we work together to make sure that we drive the training, the research, the clinical service, but also community service agenda in the northwestern part of Tanzania. So let me start by giving you a snapshot on the global burden of disease. This is a recent article from Lancet, and they have tried to look on what is happening when it comes to mortality, age-adjusted mortality of different diseases across the world for the past 3 decades. An interesting thing from this is that if you look on past 20 years, the top 10 diseases had remained relatively stable. So with the ischemic heart disease, stroke, and chronic obstructive pulmonary diseases leading. But then in 2020, when the COVID-19 came, I think there was a paradigm shift, and you could see like the COVID-19 related mortality rose to be number 2 out of these infectious diseases. And that's why we really want to work on this disease, because as part of the emerging and re-emerging infectious disease, so I think COVID-19 is one of them, and my talk will be now nested on that. And Africa has been disproportionately represented, and you could see high mortality in the African regions, but also part of the Southeastern Asia and the western part of the Europe. If you link this with the WHO dashboard in the WHO dashboard for the cases and deaths, you could clearly see like the diagnostics in Africa was extremely low, and the case notification was extremely low. Actually, Africa, we just reported 1% of the cases that have been reported in the dashboard of the WHO. But if you look here, regardless of what caused this disease, you could clearly see like the mortality during the COVID-19 period, pandemic period. Actually, Africa was actually adversely affected compared to other regions, but also compared to other countries. And this is something which was really interesting from the Institute of Health Metrics. They looked on what happened for those 30 years. So for the past 20 years, there have been tremendous improvement in the life expectancy across these countries. And in these strides, this advancement was actually paradoxically affected during the COVID-19 pandemic, because they estimated that there was 1.6 years decrease in life expectancy across the world. And what you see on the map, these are different, like the decrease in life expectancy across different countries. So you could see some of the countries are actually significantly affected in terms of decrease in life expectancy. You could see, for example, the one which are brown is, we're talking of a decrease of 5 to 6 years compared to what the advancement in terms of healthcare service delivery has been attained. And this is where now I'm resting my case, because the burden of COVID is so high. As of December last year, we had already reported over 777 million cases, approximately 7 million deaths across the world. And the rate in Tanzania, they are also relatively higher. But one thing which is striking is, which is also now in line with the emergency and critical care systems, it is the mortality among patients who are admitted. These are basically your client. These are the clients who are coming to the emergency medicine department. These are the ones who, when they go into severe or critical condition, they'll be either admitted into the high dependent care unit or intensive care unit. So you could see, for example, one study in Aga Khan showed approximately 30% of people died. And then at Bugando, we actually looked on the impact of, we were looking on the interaction between COVID-19 and non-communicable disease, and we showed that approximately 40% of patients we knew had actually died from the COVID-19, and these are the ones who actually also developed the new onset diabetes mellitus. And if you look again, there was one study which we conducted across five tertiary hospitals in Tanzania. The mortality was around 34%. So as a result now, there was a critical need to look at the inflammatory markers so that we can actually use these inflammatory markers not only to screen these patients when they come to the emergency medicine department, but also to use them as a stepping stone to do what we call risky stratifications, so that we can be more aggressive maybe to those who have certain sets of these inflammatory markers, and maybe you can also relax if you find the certain sets of inflammatory markers are present, which don't have like adverse prognostic implications. So that's why we wanted to look. But then when we looked on what is happening actually, this is the paper that we did with a consortium across the country, and you could clearly see the link between mortality and the rise in inflammatory markers if you look on the comparison between those 4 inflammatory markers. So you could see clearly here the median raising, there was a median rate, the proportion of patients who died had actually high median rate of those inflammatory markers compared to those patients who actually survived. But one thing which is now important here that I want to build in the next few slides is that we have been assessing this inflammatory marker and the outcome one-on-one. So C-reactive protein against maybe mortality, maybe D-dimer against mortality. So our interest was now, what if we combine this inflammatory marker? Which prediction potential can this combinatorial effect provide? And can it also guide our, let's say, screening, our management, our diagnostic algorithm? And this is very, very important in the emergency medicine department, but also in the critical care. So where should we target? The basis of targeting this would be in the immunopathogenesis of the COVID-19 disease. We understand over 3/4 of patients who get SARS-CoV-2 infection, they survive because they'll either have no symptoms or they'll develop mild symptoms, and therefore they will not be admitted. But our interest would be just the 25%. These are the patients who will be either severe or the patients who will be in critical condition. These are the ones who will come to the emergency medicine department, and they're the ones who will be maybe admitted to the critical care unit. And we're talking of severe viral replication in the body after infection, and then creating what we call an intense inflammatory response, and this is what we call the cytokine storm. And during that inflammatory response, that's where now these inflammatory markers that we're going to discuss shortly will be released. So we have, for example, the acute phase reactant proteins which are produced from the liver. And we're talking of like the D-dimer, we're talking of like C-reactive protein. But also we're talking of the inflammatory markers which are produced as a result of sequela. So if you look on the right here, I'm talking of visuals, the triad of COVID-19. The COVID-19 is characterized by endothelial injury, dysregulation in the clotting systems, stasis, and this all together can even lead to impaired impaired organ perfusion, DIC, and also multi-organ failure. But then during this now, and especially when you're talking of these the clotting events, that's where now the D-dimer come. So we wanted to look on how these 4 inflammatory markers can really help us in prognosticating the patient. So in our database, where I work as a co-lead together with Ali and many other colleagues, so we had a database, in our database we had over 1,700 patients, and out of these some were outpatients, so we excluded them because our interest was those who were admitted, so we ended up into getting over 1,000 patients. And again, out of this, there were a few who didn't have real-time PCR results. Then we excluded it because that's a gold standard. We wanted to make sure that we compare these inflammatory markers against the gold standard. So we ended up into having 905 patients who were admitted with the symptoms suggestive of COVID-19. But then when we did the real-time PCR, 50% of these were positive. And now those 50%, around 424, these are the ones whom our focus was. These are admitted, they were confirmed to be positive by the real-time PCR. But then because we were extracted this data in our response team, so unfortunately not all people were screened by all 4 panels, so we ended up into having only 210. These are the ones who had all the 4 parts, the neutrophil lymphocyte ratio, the C-reactive protein, the D-dimer, but also the serum ferritin. And so overall, 53% were males. One is striking things, which of course should be also expected. 47% of these were actually aged above 60 years of age. And the comorbidity was also very common with the heart disease and especially hypertension, accounting for approximately 20% of that 33%. The overall mortality, when we looked on our database after managing these patients, was approximately 30%. So that's pretty high, and that's why we really need to have mitigations. So now when we looked on these inflammatory markers, when we compare them with the severity, and this is exactly which most of the paper are publishing, looking on one inflammatory marker against one outcome. And you could clearly see that for those people who had non-severe disease, so you could see the median titer or median quantity of this inflammatory marker is relatively low compared to those who have severe disease, meaning that the higher the inflammatory marker, the more likely a patient, they are more likely pinpointing to the severe. And this was actually statistically significant to all 4 inflammatory markers. When we divided the patients into binary, 2 groups, so those who were within for 2 weeks vis-a-vis those who stayed for more than 2 weeks. So you could also see, though there was a correlation, but this was just a clinical significant, but not a statistical significant. It was only neutrophil lymphocytes ratio, which also showed the significant association between the raising inflammatory marker with the prolonged duration of hospital stay. The surviving, again, when you look on the survival, again, there was a direct significant association between these inflammatory markers with the adverse outcome. And in this case, I'm talking about mortality. So then we went ahead and reanalyzed our data by combining different inflammatory markers and see what would be the outcome. So when we combine the first figure on the top, this is what I've presented in the previous table. So you could see a progressively increase in the inflammatory markers by the severity of the disease. But then when you start now combining what you see on the left here, so when you take, for example, the serum ferritin and D-dimer, so you could see the receiver operating area under the curve here was the sensitivity of picking that was actually 86%. And when you combine 3 markers, it went to 89%. When you combine 3, it went up to 90%. So there's a perfect incremental prediction of the severity of the disease when you use this. And let me also highlight that we were actually measuring this within 24 hours of 24 hours of admission, meaning that we wanted to use them for prognosticating. And the mortality, I think the trend was also the same. You could see this is what I presented in the table. But again, when we are combining the D-dimer and CRP, 76%, and then the neutrophil lymphocyte ratio, CRP and D-dimer, you can see 78%. But when we combine four, the ferritin, CRP, D-dimer, and neutrophil lymphocyte ratio, this went to around the 79%. So the main message here now, when you take this inflammatory marker, within 24 hours of admission, they can precisely tell you whether the patient you have is going either to progress from severe to critical condition, or whether this patient will also is likely to die. So that's the message that we got from this. And this was really significant when you're combining these markers rather than just assessing one marker at a time. There was a challenge in this study because we dealt with only patients who had the real-time PCR positive results and those with only complete inflammatory markers. So you could see you're talking of 400, and then we ended up into analyzing half of them, like 200. But nevertheless, it has actually shed light into the next step. But also we excluded outpatients, so we are looking forward also to do in-depth analysis among outpatient group. And then the last one, we just did one marker within 24 hours. And then those inconsistencies in the subsequent screening, because the subsequent screening was actually dependent on whether patient is either not improving. So maybe it's high time now we also include also the serial inflammatory marker screening consistently. Maybe it's within 24 hours, maybe 48 hours, 72 hours, which is not the case at the moment because the serial one, we are doing it only when the patients are probably not improving. So in conclusion, we see high in-hospital mortality among patients with COVID-19. And in our study, it was 30%, but I reflect, if you look on those other studies from the country which I present, there were like 3 which I presented, sometimes the mortality was actually going up to 40%. And there was a significant association between this inflammatory marker with the COVID, and actually 2, the severity and the mortality. Those are the ones which were very significant. And of course, I say it again, the incremental prediction was obvious, and especially when you're combining these inflammatory markers. So what's the way forward? So we really need now to leverage on these findings. We need to leverage on these findings so that we can develop what we call context and setting specific screening, treatment, and prognostic algorithm. And when you looked on the receiver operating curve area, receiver operating area curve, the area under the curve, you could see, for example, if you want to take like a 3-based combination, if you have in a setting where the resources are not a problem, then the D-dimer, CRP, and the neutrophil lymphocyte ratio is the best. But maybe if your resources are scarce, so at least you need to have at least 2 markers. And from our data, the D-dimer and the CRP were actually the best in predicting the outcome and making sure that we stratify this patient right from the emergency medicine department where these patients should go. And actually this also dictates our aggressiveness right from the beginning and whether we should keep this patient in ICU or we should keep them in high dependent care because of the outcome is inevitable if these inflammatory markers are high. We're looking forward to do now a systematic monitoring of these inflammatory markers, not only in the COVID-19, but also in other conditions like neonatal sepsis in ICU patients, so that you can see, can we have a specific algorithm on when we should do it. But also there are other inflammatory markers like IL-6, which are currently not very widely available, so these are our future area. But then the last thing, we want now, and this is now important to this conference, we want to have a wide policy dialogue from professional association, professional councils, our Ministry of Health, and the wider stakeholders of health practitioners or experts, so that we can see how do we now bring this into our routine care. We understand these tests are available, but are not universally available in all levels of healthcare facilities. So our discussion would be, can we really make these inflammatory markers universally available? And if you want to make them available, then can we, bring them in line with what we call the rank of healthcare facility, like which one should be in tertiary hospital, which one should be in regional referral hospital, and which one should be in district hospital. These are the high-level discussions that we really want to have, because at the end of the day, these also have cost. They have cost. But the second part, we need to have also a discussion on, because this inflammatory marker, not only for SARS-CoV-2, they can also be used as a marker for sepsis. For example, we have recently conducted, one of my grad students in pediatrics, she conducted a study on neonatal sepsis and showed that when you take a C-reactive protein in combination with the neutrophil lymphocyte ratio, those two are highly predictive of adverse outcome among children with among neonates with sepsis. So we need to have now a wider discussion. How do we devise this algorithm in terms of the wide range of co-infection, especially in low and middle income countries like Tanzania. But also, as my colleague who have just presented here, she said clearly, some of the age group are disproportionately represented. For the past 20 years, our study on sepsis in children, for example, in Tanzania, is showing actual disproportionate involvement of children. So the mortality is very high among neonates compared to these other age groups. So we need also to think, can we also see how best to roll out these inflammatory markers based on the age stratification? So these are the three. They can be more than this, but these are something which we really need to discuss as professional experts, so that whatever we have is really rolled out in context. So I'm really grateful to the Emergency Preparedness and Response team. We have 3 levels, so from the ministry, from the Mwanza region, but also from our institution, but also the National Public Health Laboratory, because when COVID-19 started, the screening tools was actually centralized. So we were actually sending sample there. Fortunately, 2 years down the lane, this was decentralized, and even our institution now can routinely test COVID-19. But this data were based in the first phase, where everything was done at the Central Public Health. So we are really grateful to that. And lastly, we really welcome you. Me and Ali and other colleagues from Mwanza, we welcome you to Mwanza. Mwanza is the 2nd largest city in the country. We call it Rock City, and home to the fresh fish called the tilapia. Thank you very much, and thank you once more for welcoming me.
Asante sana. Thank you very much for introducing the inflammatory markers and stressing it out that apart from the clinical parameters that we look as clinicians, we are guided by the immunologists and by microbiologists that we have to look at the inflammatory markers as prognostication factor for critical or emergency patients. The next speaker is Dr. Mohammed Ali Musa. Dr. Mohammed Ali Musa is an emergency medicine specialist, graduated at Alexandria University Faculty of Medicine in Egypt. And he is keen to emergency care since as a general practitioner after internship in 2013. He is currently working at the Lumumba Regional Referral Hospital in Zanzibar, which is also a teaching hospital for State University of Zanzibar. He is also supervising interns and junior doctors in different emergency procedures at the ED. So we welcome Dr. Mohammed Ali Musa, and is going to talk of the emergency care, the Zanzibar perspective.
Good morning, ladies and gentlemen. I'm really glad to have this opportunity in keynote speaker, and I would like to give my topic on the emergency care Zanzibar perspective. I'm coming from this regional hospital. It's called Lumumba Regional Referral Hospital from Zanzibar. It's a 198 bed capacity. Right now we are receiving patients throughout the island of Zanzibar. Zanzibar is an archipelago on the coast of East Africa, which is composed of many small islands with two main ones, the Unguja and Pemba, with a population of around 2 million by the census 2022. The healthcare system in Zanzibar is under the Ministry of Health of Zanzibar, which is headed by the Ministry of Health, Minister of Health. It's divided into the primary, secondary, and tertiary healthcare system. The referral hierarchy of a health facility in Zanzibar is composed on the primary level with the dispensary and the health center where the health professionals are attending, and specialists are seen from the district hospital and the regional hospital where I'm working, and the super specialist in the national hospital. The importance of emergency care, as we know, it's for immediate response, which is very important for saving lives in critical situations, which ensures the proper care from arrival to disposition. Of course, the accessibility reduces the distance barriers for patients needing this urgent care. Introduction of emergency medicine in Zanzibar. It is a new specialty in Zanzibar with barely under 10 years of existence, with the first emergency department set up less than 10 years ago in 2015. The emergency study done, the quality improvement study done prior to initiating the first emergency department in Zanzibar, which shows that decreasing the morbidity and mortality of the patients receiving this critical care. The growth of emergency care in Zanzibar, as we see, the initial first emergency department was in 2015. Currently, we have about 14 emergency departments across new hospitals. Initially, in 2019, we had only one EM physician and 2 critical care nurses. Currently, we have about 4 emergency medicine specialists with 3 critical care nurses. Future plan, we have future doctors. We are about to receive 7 EM physicians and 15 critical nurses who are in school right now. The health facility distribution with the emergency department and ICU in Zanzibar. The tertiary hospital is Mnazi Moja, which has an EMD and ICU. Currently, it's in very high, very massive new renovation, so it's currently not working fully. The regional hospital in Unguja is Lumumba, which is the referral hospital from the district hospitals, which has an EMD, 6-bed capacity EMD, and an ICU of 8-bed capacity. In Pemba, we have Abdallah Mzee, which has also an EMD and ICU. This hospital, Unguja, has about 7, all with EMD, and only 1 functional ICU in GTMI District Hospital, and Pemba has 3, all with EMD with non-functional ICUs. This has increased, as you see now, this has increased from 3 emergency departments to 10 currently. The emergency department importance is to decrease the morbidity and mortality rates with quick access to urgent care. The study done at Muhimbili National Hospital assessing the mortality rates before and after opening a full capacity ED showed a significant decrease in mortality, highlighting the importance of having emergency departments in decreasing morbidity and mortality. The Zanzibar statistics study shown in 2020-2021 on access to emergency and critical care services showed that Zanzibar still has limited capacity. Government effort and strategies. The achievement currently enhanced emergency facilities have been upgraded to emergency care facilities and increased viability of ambulances. Of course, improved training, more comprehensive training programs for healthcare workers in emergency care. Increased awareness, the public now has been aware about emergency service, and increased access to education. Most healthcare professionals have gained access to education and specialized training through scholarships and international partnerships. Despite these challenges, the Ministry of Health is committed to improving quality of care. The government prioritizes healthcare by increasing hospital numbers to ensure accessible quality care for everyone. Challenges in emergency care, we have the limited resources, shortage of trained personnel, and of course with medical supplies. The ambulance services delays with lack of proper equipment, triaging, need for better prioritization of critical cases, and also the referral system, slow patient transfer process. As was said earlier, that Lumumba Regional Hospital is receiving patients from different district hospitals in the country, but not all services are available in the hospital I'm working. For example, neurosurgical. So patients with severe traumatic brain injuries, they were delayed in treatment by bringing them to Lumumba because neurosurgical department is not available in my place. So slow patient to transfer process is also challenging emergency care in Zanzibar. Recent improvements and interventions, government have done initiatives in upgrading emergency units by increasing ambulance availability also, but also we don't have the EMS system running around across the country. Training program for healthcare professionals on emergency response, and also introduction of the BLS and ACLS training in the country. What should be done now to improve? We need to critical expansion by increasing the number of staffs, number of emergency facilities, and also we need to increase these departments by ensuring they are fully functional at the district levels. Nevertheless, continuous updating knowledge needs to be provided to these staffs. Ongoing training and upgrade the facilities, and of course improving the working conditions for the personnel working in the ED and critical care units. The future plans and goals, expansions, more hospitals must be built in and EMDs with trained personnel, increasing the number of trained professionals in the EMD and ICUs, but also with quality improvement, ongoing efforts to enhance emergency care service throughout the country. I'd like to conclude my talk on conclusion. Emergency care in Zanzibar faces significant challenges, but is improving. We need to be having collaborative efforts from the government, NGOs, and communities are very essential. Investing in training, infrastructure, and community education is also key of success. And thank you so much for listening.
Thank you very much, Dr. Mohammed. Our next speech talk is not going to be here. We regret for that, for the reasons beyond our control. So we cancel the leadership in emergency medicine. Dr. Brett Nix could not make it to Tanzania. So at this juncture, we would like to use this time to invite the panel, the speakers over the stage. Professor Brittany, Professor Seni, Dr. Joseph, and Mohammed over the stage for the questions and answers. For anyone who will have the question or the comment, the opinion.
Thank you, Dr. Seni, for showing the value of doing pertinent research that is actually, as mentioned by Dr. Boni, very influential even on a global platform. My question is, looking at cost effectiveness, cartridges for CRP, public health approach, rather than just in terms of tertiary care, are there any particular plans in making sure the biomarkers are not rolled out as a public health approach as we usually do in our setups, but streamlined to indeed candidates that really require that batch of tests? Thank you.
Normal African.
Should I respond?
Yes.
Oh, thank you. So thank you very much, Doctor, for that question. As I said, like those are the areas for, if you remember my last slide, I think we really need a wider policy dialogue on that. At the moment, for example, in Tanzania, if I could give a reflection in Tanzania, all these tests are actually covered by the National Health Insurance, but then they are not covered all the way down to the primary level healthcare. So they are covered at secondary level, that's a regional referral hospital, and tertiary hospitals. So probably we need to, based on the data and maybe other data which will be generated elsewhere in the country, we need now to see which one among these four will now go to the primary level, because that's where the majority of our patients attend for their routine healthcare. But then the good thing again in Tanzania, I think if you're aware, we are looking forward to the universal health coverage. So I think this is the optimal time for discussion, so that when that universal health coverage is now rolled out across the country, we really need to advise them, informed by this evidence, like which one should go in which level of healthcare facility. Yeah, we have a project in Zanzibar at the moment. It's called a Zantoto project. So it's a project, we are using the CRP as a point of care test to improve the neonatal, actually to guide the doctors whether to prescribe or not, but also to improve the neonatal outcome, to foster antimicrobial stewardship, and ultimately to reduce the burden of antimicrobial resistance. So in Zanzibar, we are specifically optimizing it in all levels of healthcare facility, from district, regional, and tertiary. So we have Mnazi Moja Referral, which is a tertiary hospital. We have Mkoani, Abdullah Mzee Haji, Mkoani Regional Referral, and then we have 3 district hospitals. So in Zanzibar, at least we are generating the data which will build a case for support that some of this inflammatory mark can actually be trickled even down into the primary level. For example, we have rolled out this to like 3 district hospitals, and this is a quantitative CRP, a point of care test at the doctor's bench, so that when you finish up seeing a child history taking examination, then your assistant do it for you quickly, and then you decide whether to use antibiotics or not. So we are building this evidence for support, and we're looking forward now to expand the scope to many more other infectious diseases. Thank you.
Okay, my name is Dr. Noel. My question will go direct specifically to Dr. Mohamed. I just want to know, is there any specific community-based training or initiative done in Zanzibar to improve the basic knowledge on the society about basic emergency care?
Thank you so much, Doctor, for your question. Yes, there are some initiatives done by the Ministry of Health with collaboration with the emergency specialists available. Of course, with collaboration with EMANT and EMSA to the country. Last year, in August, SEMKI was done, symposium concerning the emergency care and critical care in Zanzibar was done, collaborating participants from different hospitals from the community level. Thank you.
Thank you. you very much, our speakers. So, go back to it. Thank you very much. Oh, may I welcome the director of the SQF to present the award for the speakers. Dr. Mabula, please welcome. Nani? Dr. Muhammad Ali, please come. Professor Jeremiah Seni. Thank you. All right. Thank you very much. Now we are going for the tea break. Let's observe time and study the breakout sessions that you'll be interested to attend. Thank you very much.
Na mtazamaji wa SQF TV kupitia YouTube yetu live unatupata moja kwa moja tukiwa hapa Green Milea, ukiwa ni conference mkutano wa pili, ambapo leo itakuwa ni hitimisho, ikiwa ni tarehe 14 ya mwezi wa pili, hitimisho ya conference ya the Arusha Emergency Medicine Conference, ambapo muda huu wamepresent topic zao, wameelezea hapa mbele na watu wamepata kuelewa. Sasa hivi ni muda wa break, tutakaporejea tena tutaungana na wewe moja kwa moja kutokea hapa Green Milea. Jina langu ni Pendo Ogotoni, fundi mitambo alikuwa Pantale Ulugusha, lakini pia nyuma kamera yupo Dani. Nikutakie wakati mwema. Muda wa chai sasa. Msimu wa 4 wa kutoa mafunzo ya huduma ya dharura, kama nilivyokuambia kwamba nitakuwa nakupa update kile kinachoendelea hapa Green Milea. Nipo na mmoja mshiriki ambaye amekuja kushiriki katika conference hii. Tutaka kusikia kutoka kwake ni kwa nini ameamua kuja kushiriki katika conference hii, lakini pia matarajio yake ni yapi. Karibu sana, habari yako?
Asante, naitwa Dr. Muhammad Ali Musa, ni daktari bingwa wa magonjwa dharura. Nafanya kazi katika hospitali ya mkoa wa Lumumba.
Hebu tuambie ni kitu gani hasa kilichokuvutia kuja kuhudhuria katika conference hii ambayo inatoa mafunzo ya huduma ya dharura?
Kama daktari bingwa na magonjwa ya dharura, tunapaswa tuwe tunajijengea uwezo kila mara kuwa updated. Kwa hiyo ujio wangu hapa katika kongamano hili ni kujua update guidelines ya mafunzo mbalimbali yanayohusiana na magonjwa ya dharura. Na mimi binafsi nashiriki katika warsha ya magonjwa yanayohusiana na dharura za moyo. Kwa hiyo pale unakutana na wakufunzi mbalimbali wanaotoka Marekani, wanaotoka nchi jirani ambazo wamekuja kutujengea uwezo washiriki katika kujua huduma za dharura katika masuala ya moyo unayafanyaje, guidelines za sasa zinasemaje. Kwa hiyo mafunzo haya ninapochukua, bila shaka narejesha kwenye kituo changu, na kule kituo changu nitafaidika kwamba ni huduma za updated za kisasa na dawa gani zinatumika kwa kisasa, na of course kutengeneza link pamoja na wataalamu mbalimbali wanaotoa huduma za dharura ndani na nje ya nchi.
Kuna baadhi ya tunavyojua kwamba konferensi hii haijahusisha tu peke yake madaktari, kuna matrafiki, kuna walimu, kuna waandishi wa habari ambao wamekuja kuhudhuria katika konferensi hii. Kitu gani hasa ambacho unawashauri watu ambao waliona tangazo hili lakini pia kuhudhuria? Kitu gani ambacho unatoa wito kwao ili next time waweze kuja kuhudhuria?
Kusema la kweli, huduma ya dharura ni kwamba inatokezea kama jina lake dharura, anytime. Kwa hiyo anytime, popote ulipo, nyumbani, makazini, ukiwa njiani, ukiwa hospitali. Kwa hiyo kujua kutoa huduma dharura sahihi, basi lazima upate mafunzo sahihi kwa wataalamu sahihi. Kwa hiyo huduma dharura nazo zinatolewa hata kwa watu ambao si wataalamu wa afya. Kama uzungumza, kuna waokoaji kwa tuseme zimamoto, wanawezekana si watu wataalamu wa afya, lakini mafunzo ya aina hii yatawajengea uwezo panapotokezea janga la moto katika maeneo yao ya kazi, vipi waweze kuokoa na wao bila shaka kuweze kujisalimisha. Yani unapotoa huduma dharura, mwanzo safety comes first. Yani wewe mwenyewe unatoa huduma, uhakikisha yale mazingira ni salama, then ukatoa huduma kwa wale ambao anahitaji huduma hiyo. Sawa? Sasa kwa hiyo tukiwajengea uwezo wale ambao si wataalamu wa afya, kwa mfano tena anarejea wazima moto, basi anajua kwamba moto una athari gani, vipi ajilindee mwanzo kabla kumpa huduma mwingine.
Hii ni mara yako ngapi kushiriki katika conference?
Ni mara yangu ya kwanza kushiriki katika conference na hii hapa Arusha. Ni mara ya kwanza kufika ndani ya jiji lenu nzuri sana la Arusha. Kwa hiyo nina furaha kuwepo hapa, na siku ya pili leo kuendelea na mafunzo haya, basi ninaona ni mafunzo gani ya ziada nimeyapata na vipi nitafanya kazi.
Yes, hii ni siku yako ya pili, lakini pia tunaendelea mpaka ifikapo Ijumaa ya tarehe 14. Wewe unadhani ni kitu gani pia tuboreshe ili katika mafunzo mengine yanaendelea siku ya kesho na siku ya Alhamisi na Ijumaa tuweze kukiboresha ili wewe ukapata kuenjoy zaidi?
Asante. Mimi mmoja hapo nikiwa ni mmoja wa wazungumzaji katika conference ya kesho kutu, basi ninakaribisha kwa kweli wale ambao hawajafika bado katika eneo hili la Grand Melia waje wajifunze. Kuna topic mbalimbali zinatolewa na wataalamu. Mimi topic nitakayozungumzia ni emergency kwa Zanzibar. Kwa hiyo kama tunavyojua, emergency ni moja ya fani mpya katika utaalamu wa tiba ya afya. Basi kwa hiyo nitazungumzia kwamba Zanzibar tulitoka wapi, sasa tuko wapi katika huduma ya afya ya dharura, na wapi tunategemea kwenda katika huduma ya afya ya dharura.
Kulisema tumalize kwa kusema the same qualities foundation, hatua moja tabasamu moja. The same qualities foundation, hatua moja tabasamu moja.